afternoon, everyone. It is my great honor to be part of the second annual Congress of the Philippine Society for Fertility Preservation. Today, together with Dr. Nico Magsanok, we are going to talk about the options of ovarian and testicular tissue cryopreservation. Honestly, there's a lot to talk about in pre-pubertal OTC, but this lecture will be focusing on the following. According to the literature, ovarian transplantation was first practiced in 1985 by a surgeon in New York named Dr. Morris. But in this era, experimental studies are not yet practiced. After almost a century, experimental studies in animals were started in this field. And it was in 1994 when Dr. Gosden from UK was able to achieve a live birth from a sheep. He was able to establish an experimental model for ovarian tissue transplantation. Until starting 1999, Dr. Octay and his team has made a lot of advancements as well when they were able to produce the first orthotopic, heterotopic, and first embryo after heterotopic, although this does not result in pregnancy. Finally, it was in 2004 when Professor Dene and his team reported the first live birth after OTT through orthotopic transplantation. After that, there has been an increasing number of live births from orthotopic and slow freezing. It was at the year 2010 that Professor Suzuki from Japan tried and introduced the protocol ovarian tissue vitrification. Currently, we have at least 200 live births from OTC, and it was in 2015 when the first live birth happened from a case of prepubertal OTC transferred after 10 years. General concept of OTC-OTT includes excision of an ovary. The cortical tissue, which includes the follicles, are separated from the medulla and is then preserved through the process of slow freezing or vitrification with the goal of transplanting it back in the future to the patient. Now, speaking of transplantation, there are two sites on where you can transplant the ovarian tissue. Heterotopic is if when you transplant it outside the pelvic cavity. For cases where orthotopic is not feasible, and one downside is spontaneous pregnancy is not allowed, but it is done if the aim is just to restore ovarian activity. You do orthotopic when you transplant it within the pelvic cavity. It is the more common site, and it's the one that produces spontaneous pregnancies, and it is recommended if the aim is to get pregnant and produce live births. Here are examples of your heterotopic. The forearm and abdominal transplantation. As you can see, the ovarian activity are evident during the follicle monitoring. Lateral pelvic wall peritoneum is an example of orthotopic, as well as your transplantation into the ovary and on the ovary. Now we're moving to the fundamental factors of this process. First question, is it safe? It generally has a low risk with 0.2 to 3% complications. In prepubertal OTC, infection and drug allergy were the complications reported. From a systematic review done by Corkum, containing several studies, very few cases showed complication, which includes minor and major bleeding. Second issue is the follicular loss in this process. Each step contributes to a different extent to the overall decline in follicle numbers, starting from the initial reserve, next when you start the graft preparation, during the freezing and thawing, the choice of transplantation site, the surgical skills, and the ischemic damage brought about by post-transplantation loss. The dormant follicles are the ones that are being preserved. This may explain why the return of endocrine function and the production of mature follicles on average 4 to 5 months after transplantation, a time period that aligns with the 4 to 6 months that is believed to take for the primordial follicles to develop in the human ovary. Since most of the follicular loss happens during the post-transplantation state, effort should be really focused on optimizing the survival of the primordial follicles during this period. Third fundamental issue is the minimal residual disease, which according to Dolmans is the very limitation of ovarian tissue cryopreservation and transplantation due to the possibility of transferring malignant cells back to the patient. The ways to check for malignant cells aside from histologic assessment is doing molecular studies using your gene expressions, your NGS, FISH, flow cytometry, and also the long-term xenografting experiments. In Japan, one of their experiments is towards creating an artificial ovary to reduce the reimplantation of minimal residual disease. This is a table we can use as guide for assessing which of the cancers are high risk for MRDs. As of now, the highest is in patients with leukemia, neuroblastoma, Burkitt's lymphoma, and ovarian cancer. Next, what's the use of OTCT? We can use it for induction of puberty and future fertility of patients. There are already 2 reported cases of prepubertal OTC that resulted in successful pubertal induction, one in 10-year-old and another in 9-year-old with sickle cell disease and Ewing sarcoma respectively. And transplantation was done 27 months and 4 years after. Now, what are the pros and cons of this procedure? The advantage aside, of course, for possible pregnancy and pubertal induction, there is no need for regular oral or transdermal medication intake as HRT, and it requires only subcutaneous tissue transplantation. Disadvantages include possible minimal residual disease, the individual duration of ovarian activity cannot be foreseen and is limited. If you need to stop the hormone production at some point, the only way is to do it surgically. Lastly, the sudden increase in estrogen may impose potential side effects such as accelerated pubertal growth and premature closure of growth plates. Next issue is its effectivity. In general, after the first live birth case was reported in 2004, it is estimated that around 200 live births were already achieved in 2020. In prepubertal, there are already 2 cases of live birth that have been reported in patients who underwent OTC before menarche, before 9 years old and 13 years old. First of those live births was in a 5-year-old patient with sickle cell anemia. The OTC was done at 13 years old and transplanted when she was already 23 years old. And after 2 years of OTT, spontaneous pregnancy leading to a live baby boy happened. Now we're moving forward to the special considerations in prepubertal patients. Edinburgh criteria is one of the popular guides for ovarian tissue cryopreservation. It includes doing the OTC, less than 35 years old, no prior chemotherapy if the patient is more than 15 years old, while if the patient is less than 15 years old, there should be mild non-gonadotoxic chemotherapy, and there should be a realistic chance of 5-year survival. There should be a high-risk premature ovarian failure and no pregnancy and no own children. Professor Tekay proposed an updated version of the Edinburgh criteria, which divided the guidelines into 3: reproductive aspects, conditions of the primary disease, and the safety and ethical aspects. In the reproductive aspects, aside from more than 50% risk of POI, he is suggesting that there should be a remaining reserve. Under conditions, he emphasized that the disease should not be ovarian cancer, with at least 1 ovary is normal, no peritoneal dissemination lesions in imaging diagnosis, and no giant tumor occupying the abdominal cavity. The uterus should be intact, and a hysterectomy will not be needed in the management. Lastly, in leukemia patients, morphological or, if possible, molecular complete remission is needed. For the safety and ethical aspects, the primary doctor should have permitted the procedure. The 5-year survival rate is at least 5%. The patient can withstand the surgery. There is an informed consent from legal guardians, and that psychological conditions should be assessed and deemed acceptable prior receiving any treatments. Moving forward, another thing to consider is handling prepubertal ovarian tissue. The prepubertal ovary is fundamentally different from the adult ovary in that the ovarian volume increases with age. The border of the ovarian cortex and medulla is not clearly delineated, and the fact that there are more primordial follicles in the prepubertal ovarian tissue. Another issue is the surgical aspect of OTC. We need to consider the small body of the pediatric patients and possible complications from close proximities of the ovaries to the adnexal structures. Here comes the role of pediatric surgeons. Their skills are set to perform surgeries on even the smallest children if to be compared to reproductive medicine specialists who do not routinely operate on pediatric patients. And this is very important to collaborate with pediatric surgeons when doing this procedure. For minimally invasive surgery, the number of ports is reduced to as few as possible. A represents laparoscopic port alignment for an infant. B is for the peripubertal children, while your C represents the postpubertal girls. Basically, single port surgery using 15 to 20 millimeter incision is performed for patients with a developed large ovary. However, multiple port surgery is performed for patients with immune dysfunction and bleeding tendency. Now, when you're about to perform the procedure, these are the factors you need to consider at different stages. During the pre-operative stage, you check for baseline hormones, secure clearance, and properly conducted pre-op planning with other specialties. During the operation, laparoscopy is the method of choice. The right ovary is preferred since it is further from the sigmoid colon. The surgeon should implement a no-touch, minimal manipulation technique. After the operation, same-day discharge is encouraged. Chemotherapy can begin as early as 3 days after surgery, and radiation can begin 7 to 14 days after surgery. The long-term follow-up should then again include your monitoring of hormones. In addition, you also monitor for pubertal development and the presence of ovarian function. Lastly, you should be open to cancel your patient for a possible oocyte cryopreservation once she reaches pre-pubertal age. This is a slide of ovarian collection for the youngest childhood patient in St. Mariana, Japan, and a 14-month-old patient with AML. Now, another very important issue in prepubertal OTC is, of course, obtaining informed consent. Minors are persons under 18 years of age, and the term may be used interchangeably with the term children, and minors are considered as belonging to a vulnerable population. Requirements for the guidelines involving minors or children are legally authorized representative and assent, either in oral or written form. Here's the list of the guidelines of American Academics of Pediatrics 2020 in offering fertility preservation treatments in children. Physicians providing cancer treatment to children should be able to counsel patients and their families regarding the risk of infertility and fertility preservation options. There should be a timely referral. Physicians who provide cancer treatment should be aware that fertility preservation options are limited in prepubertal children and that most treatments in this age group are experimental in the present time. When counseling families regarding fertility preservation, physicians should be clear as to whether the treatment have proven efficacy or are experimental in nature, and experimental therapy should only be undertaken under IRB approval. In a single prepubertal OTC center published by Professor Takai, if the patient is more than 16 years, they require legal guardians and informed consent from the patient. If less than 16 years old, informed consent is sought after the presentation of visual and videographic information to explain fertility preservation. Posthumous assisted reproduction was also included in their counseling. An analysis of parents' and patients' decision-making was studied by the team of Sullivan Pike, class 2018. This showed that the desire to have genetically related children and to prevent the psychological distress of infertility are the two most common that largely drove parents' decision for their kids. They also compared the answers of the patients and the parents, and they both agree that OTC is the right decision for them. They both believe that frozen ovarian tissue can be used in the future to restore fertility, and that ovarian tissue cryopreservation is a good idea, and OTC can also be offered to lower-risk children. Study respondents were hopeful that in the future, successful pregnancy could be attained using this technique. More importantly, the patients believe that they should be included in the decision-making. Lastly, the issue on whether prepubertal OTC is experimental or non-experimental. While OTC holds promise, it is considered an experimental procedure at this time by Donay, Dolmans, and Octay. However, on 2019 ASRM stated that OTC should be considered an established method but with limited effectiveness. They also stated that ovarian tissue cryopreservation is no longer considered experimental and can be used in prepubertal patients or when the time for ovarian stimulation is insufficient. Being those said, these are some points to remember on deciding on whether this should be labeled as experimental or non-experimental in the country. Information about the clinical practice of fertility preservation in children and adolescents is still scarce. Compared with adult cases, experience with fertility preservation for children is limited. Particularly in Asia, few attempts to thaw and use preserved oocytes and ovarian tissue have been made because fertility preservation started later in Asia than in Europe and the USA. The technique of OTC use also matters if it's freezing versus vitrification. Now, for the conclusions, the oncofertility program in children is best implemented with a large tertiary center embracing the multidisciplinary team, which provides the possibility of staged and well-timed medical care. More research is required for the improvement of counseling, selection criteria, and surgical and thawing techniques in OTC. OTC is the only fertility preservation treatment in prepubertal girls. Hence, it is and it should be discussed with all patients